Hi, my name is Bob Tomic. I'm the chair of the Surrey Prostate Cancer Support Group, June 25th, 2022. Precision Cancer Medicine expert Alex Roland is Chief Research Director and co-founder of Cancer Treatment Options and Management. Alex has 25 years experience as a highly respected research scientist in the field of precision cancer medicine and Oncology, and did his PhD studies in medical genetics at University of British Columbia and the renowned Terry Fox Laboratory in Vancouver and the British Columbia Cancer Agency. He has spent time on the frontier lines with patients and in hospitals, in labs, researching the new diagnostic and treatment advancements, and also works directly with the medical system to explore the newest optical treatments for his clients. He is currently partnering on numerous clinic trials with leading-edge hospital and biotech companies. Alex has developed highly successful treatment plans for oncologists and patients at leading cancer centers around the world, including the Mayo Clinic, Johns Hopkins, MD Anderson, BC Cancer Agency, Princess Margaret Hospital in Toronto, Cross Cancer Hospital in Calgary, the Bowen Icon Cancer Centre, New Zealand, and the Cabernet Hospital in Australia, among many others. He is recognized among the best in the industry as an expert and thought leader. Alex is dedicated to ensuring that everyone who receives a cancer diagnosis has access to the most effective and least invasive form of treatment possible. Please welcome Alex Roland.
What a great crowd. It's wonderful to see everyone here on a beautiful day. This is my first public presentation in well over 2 years. Everything's been done on the internet over the last few years, and so I feel like an animal who's been let out of his cage. So it's great to have the real human contact and be around people again. And so in creating today's presentation, I had to think long and hard. There's been so many amazing new advancements in precision oncology and cancer treatment over the last few years. We're really starting to get a handle on it. And there's about 300 different seminars and conferences every year internationally. And some of those, like ASCO, American Association of Clinical Oncologists, can have up to 9,000 different publications. So the amount of data coming our way is massive. Just a huge amount of clinical trials, hundreds of thousands of clinical trials going on, many different new drug combinations and technologies. So what I want to do today is tell you about some of the latest treatments that are now becoming publicly available. And I focus today on drugs and protocols that are available in Canada. They may not be widely used yet, but they're definitely showing some great results. And so before we get started on that, I wanted to do a bit of a background on what cancer is and what prostate cancer is specifically, and how it starts, and where the science is and what directs it. So there'll be a little bit of a learning curve to get started, but hopefully everyone will, if you have any questions, feel free to ask and interrupt me at any point in time, and I'll try to explain everything in layman's terms. Most of the slides I'll be presenting are from a continuing medical education seminar that I recently attended, and there's some really great stuff there, so I hope you all enjoy it. So first off, we're going to talk about what prostate cancer is, what starts it, how it forms, and how it's treated traditionally, which is what we call standard of care. Now, standard of care, or SOC, changes where you go. And I like to use the term, the future's here now, it's just not well distributed. And so that's how I like to look at standard of care. Is the standard of care at Mayo Clinic or MD Anderson may not be the same as the standard of care in Saskatchewan. So it's important to understand that cancer is an international disease, and we need to fight it on an international level. So we're going to be talking about innovations in prostate cancer treatment, and we'll explain why they work better. So basically, what is prostate cancer? So I'm sure you've all heard of the androgen receptor. Prostate cancer is basically caused by overexpression or overactivation of something called the androgen receptor. The androgen receptor has something called ligands, and they're referred to as androgens. And when the androgens bind the androgen receptor, it causes a change in conformation in this receptor in the prostate cells, and then it goes into a process where it causes these cells to grow. And this is a normal, healthy process. It normally goes on, it replaces prostate cells throughout our life. It's a normal, healthy process. So to better understand how prostate cancer forms, we're going to go into a little more detail on this. So what is a receptor? A receptor I like to envision as something that occurs on the outside of a cell. Any cell in the body has a receptor. We have many different receptors, and there's different types of receptors. The androgen receptor is a unique receptor because it actually occurs inside the cell. Most receptors have a portion that is inside the cell and then also outside of the cell. But the androgen receptor is located actually inside of the cell in the cytoplasm. And so what happens is when the ligands for the receptor bind, which are testosterone and dihydrotestosterone, when they bind the receptor, they're called ligands. When they bind it, it triggers a change in the shape. And this androgen receptor will then travel into the nucleus of the cell, and it will tell the cell to turn on certain genes, and those are the genes that are involved with growth and development and copying of the cell. So obviously when something goes wrong there, then that's what we call cancer. And so cancer is a disease of the genes. We have 25,000 genes or so, and every cell has different genes turned on at different times, and that's what creates our multicellular body. So in cancer, what happens is the cells that are involved with growth and development that are normally turned off in our embryonic state, or when we become adults, those cells get mutations and they get activated again, or those genes get activated again through various processes. So once the ligands have docked the androgen receptor, this sets off this signaling cascade change. The androgen receptor goes into the nucleus and it turns on the cell and it tells it to proliferate. So prostate cancer cells have too many of these androgen receptors or overactive androgen receptors. So there are a few different ways prostate cancers can develop. You can have an overabundance of androgen receptors, or you can have mutations in the DNA of the androgen receptor. In other words, the coding that creates the androgen receptor can have various DNA mutations. There's a few different DNA and RNA mutations that are fairly common. One of them is called the ARV7, and the other is called the ARV9. AR always stands for androgen receptor. And so basically, these are just two different forms of the androgen receptor, and they're truncated. They're not full-length genes. So there's some damage that happens to them, and you get these shortened versions of it. And I'll explain why that's a problem in a moment. There's also, you get these mutations. One of the mutations is called the F877L. And basically, when you see a gene symbol and then you see a alphabet number and some lettering, what that tells you is it tells you that the original amino acid at that position has been changed, and that's what we call a mutation. So in this particular case, for the androgen receptor, there is a amino acid designated as an F at the 877th position, and that's been changed to an amino acid called L, which stands for leucine. There's another one, which is a W amino acid, and it gets changed at the 742nd position, also to a leucine. So these are mutations that will cause the androgen receptor to overactivate or to stay turned on and to produce too many prostate cells. And then there's also alterations in a signaling pathway called the PIK PTEN AKT signaling pathway. Now this is common in many cancers, but in this particular case, it leads to a very difficult and hard to treat form of prostate cancer. So we're going to talk about that. I'm sure you've all heard of it. It's called castration resistance, metastatic prostate cancer. And so that's often caused by alterations in this pathway. So we're going to talk about how to deal with that. Another unique feature about the androgen receptor is it has an area of it that has a variable length of something called CAG repeats. CAG are just 3 different DNA base pairs. C is one DNA base pair, A is another, and G is another. And you get this triplet repeat. And so the amount of these repeats tells the androgen receptor how sensitive it is to stimulation by testosterone and dihydrotestosterone. And so if you have more of these repeats, it's less sensitive. And if you have fewer of these CAG repeats, you have much more increased sensitivity. And so certain different populations of people, different ethnic groups have more or less, and that changes. And one example is African Americans. They tend to have fewer CAG repeats in their androgen receptor, and therefore it creates a higher sensitivity or a higher risk of prostate cancer for African Americans. So how do we diagnose prostate cancer? I'm sure most of you are familiar with this. It typically starts with an increased elevated PSA. Then you get what's called the PSA doubling time. How many months does the PSA double in rate? Then it's typically you get a CT scan or an MRI, and then you get a bone scan. As most of you know, prostate cancer preferentially metastasizes to the bone, so that's one of the first complications. Many people who get diagnosed with prostate cancer end up having a broken bone or from a fall or something, and then the doctors will do a scan and they'll notice, oh, you have this lesion on your bone, and they'll do further tests and notice that there's increased PSA. So always be aware of bone pain or falls or breaks or anything that don't heal, because that could be an indication that you have some sort of metastasis to the bone. So obviously the next step is if you get a biopsy for your prostate, they'll take a bunch of different cores and they'll come up with a different amount of material, and then they'll do something called the Gleason scale. So I want to talk to you about a new technology in prostate cancer. It's called the PSMA PET-CT scan. It's actually been around for about 5 or 6 years, but this is one of the most amazing new technologies. And interestingly enough, a lot of this technology has been developed in Canada. Although it's not used in Canada much right now, that should change very quickly. You can get PSMA PET scans privately. And there is a government program, or there has been a government program on and off over a few years where they've experimented with the PSMA PET. There's a variety of reasons a PSMA PET is important, and we'll get into that. But first, let's talk about what PSMA is. It's not PSA. PSMA is referred to as a prostate-specific membrane antigen. And an antigen is something that attaches to the outside of the cell so the immune system and the body can recognize that cell as a prostate cell, for example. So this is basically like a little flag on the outside of the cell, and it says, I'm a prostate cell. And if I'm not in the prostate, something's wrong. I'm only supposed to be in the prostate, and if you see me traveling through the body, then something's wrong, because prostate cells are only supposed to stay in the prostate. So the PSMA antigen is found in about 99% of prostate cells, whether they're cancerous or not. And since prostate cells are only supposed to be in the prostate, then if you see a scan, or if you have a PSMA scan and you see these cells, then you know it's from metastatic disease. So one PSMA PET scan can be about 92 to 95% accurate. In other words, it's really good at finding all of the metastatic lesions in the body, compared to CT and bone scans, they're much cheaper, but they're not as effective. 65% around that, 50 to 65% accurate. So I'm going to give you an example of what a CT scan looks like to a radiologist or a doctor. The important thing about a CT scan, I don't personally read CT scans, but I know a lot of people that do, and how they do it, I just don't know. I mean, it's like black and white shapes and shadows. The other thing with the CT scan is it doesn't tell you whether that lump that they see is a tumor or not. It could be a marble you swallowed as a child, or it could be a benign lump. Basically, what it shows you is differences in tissue density. And the way it does it is it fires a beam of radiation through one side of your body. There's a collector on the other side, and different tissue densities will pick up different amounts of that radiation beam. So if you have a denser area in your bone than the surrounding bone tissue, then that will show up on a CT scan as an area that has received less radiation on the collecting plate, and therefore the computer will turn it into an object, and it will say you have a density here. It's either more dense or less dense, and it could be a tumor, but it doesn't tell you for sure it's a tumor. And we have a lot of these different things, cysts and so on. The beauty of PET imaging is it tells you in real time whether you have a tumor or not, because it looks at something called metabolic activity. And so I'm going to show you a picture of a PET CT. And as you can see, it's very different. So the yellow lumps there are all metastasis, and basically they glow like a Christmas tree. And so what PSMA is they have this molecule. It's like an antibody. The original PSMA scans used an antibody. Now they use something called a small molecule. And I'll show you a slide of that later, because we're going to talk about a really fascinating subject called Theranostics. We'll get into that a little later. But basically what a PSMA PET scan is you have a radioactive isotope. It's typically gallium, but there are many different radioactive isotopes. And they attach a molecule of this radioactive isotope to a small molecule that is designed to bind onto this PSMA molecule anywhere in the body. So anywhere there's a PSMA receptor, this small molecule will find it in the body and it will attach to it. And then it will attach this radiation, or this little lump of lutetium. And so then when you get a scan under a CT, it actually glows like a Christmas tree bulb. Versus this white shading and so on that you get from a CT. So this is a very important development, and definitely, it's changing the way people are treated. We had a person come see us recently, and they're going for surgery, but they'd only had a CT scan and a bone scan, and we recommended they get a PET CT, and they got one locally at a private clinic. Their doctor signed for. You have to get a doctor's signature for a PET CT, but most doctors are very open to that. And so he went for a PET CT, and they found that he actually had some metastatic lumps that were not noticed on the CT scan or the bone scan. And since he was going in for surgery in about 10 days, that altered his surgery. And his surgeon was actually able to take out these lumps that would have been left behind had he not had a PSMA PET scan. So, it's a life-changing scan. Proper diagnostics is really important. So we're just going to talk about standard treatments for prostate cancer. As you all know, if you have localized prostate cancer, and it's confined to the prostate, then typically you get surgery and then radiation. You can also get brachytherapy. Brachytherapy is a type of radiation where they insert little radioactive rods around the tumor, or they can insert these tubes and then have a liquid radiation a solution go through the tubes at various points in time. And then, of course, ADT is pretty standard. I'm sure everyone knows what ADT stands for, androgen deprivation therapy. And there's a bunch of drugs that we've had around for many, many years that work for that. So there's many different drugs. A lot of doctors have their own personal preference of a certain drug, of one drug over another. So I'm sure most of you are familiar with that. So if you have metastatic prostate cancer, then you've probably heard of androgen receptor antagonists. These are a fairly new development in prostate cancer treatment. And basically what they do is they bind onto the androgen receptor and they prevent that androgen receptor from going into the nucleus and turning on the proliferation cycles and the different cycles of genetic expression that occur in prostate cancers. And so right now we actually have 4 different androgen receptor antagonists. And so we have one called abiraterone, there's enzalutamide, there's apalutamide, and then there's a relatively new one called darolutamide. Darolutamide is sort of the latest incarnation of an androgen receptor. I think it's just passed the full approval process now. It's been tested for many years in clinical trials, but it's considered the new gold standard for an androgen receptor. So what typically happens when you get, when you find a particular mechanism in cancer for cancer treatment, what happens is one company will come along and they'll make a drug for that. And they'll say, oh, we've got this great drug, it targets the androgen receptor. And then another company is going to come along and say, we learned from your mistakes and we've got a better drug. And our drug is a little better than your drug. And then some other company is going to come along and say, you know what, you guys did a great job, but we're taking it next step further. We're making a better drug. And so you have all of these companies competing to make the best drug. And I think that's great because this technology needs to be out there. So typically we refer to these as first, second, third, fourth generation drugs as they go through this approval process. So darolutamide is the latest incarnation, and darolutamide was designed because abiraterone, enzalutamide, and apalutamide all are able to go into the central nervous system. They can cross the blood-brain barrier. And because of that, it results in side effects that I'm sure most people are aware of, like confusion. It can even cause strokes and other problems. So these drugs in the brain can be a bit of a problem. So when darolutamide was designed, they designed it so it wouldn't enter the CNS. It wouldn't cross the blood-brain barrier, and so it would have less effects. Now, that could be a double-edged sword because it could, drugs that enter the CNS are going to protect you against a brain metastasis. So maybe darolutamide is not going to be as valuable as protecting against brain metastasis, but it's going to have less side effects. And so there's a lot of different back and forths and studies and so on and confusion on which androgen receptor antagonist is the best. And I hear from doctors all the time saying, oh, I love apalutamide, it's the best. And then another doctor will come along and say, oh, no, abiraterone, I've been using it for years, it's wonderful. And another doctor will come along and say, well, enzalutamide, I've never had a problem with it. So I thought it would be great to just talk a little briefly about these different androgen receptor antagonists and just tell you how they differ, because there's a lot of misinformation on how they differ. And so a lot of times a doctor will want to look at not necessarily how the drug works, but their experience with it and what the side effects are and how well it works in their experience. So doctors are in the trenches, they're treating and they're dealing with real life situations. As a scientist, we're kind of up in our ivory towers and we're saying, well, this is the mechanism of this drug and this is the mechanism of this drug. And so that's what I have to share, is how these drugs work. So obviously you also know too that another solution is chemotherapy. So, abiraterone, how does it work? It's a unique androgen receptor. What it does is it inhibits the conversion of testosterone to DHT. DHT is dihydroxytestosterone. And basically, that process occurs inside of the cell. And one of the important things is DHT has a 5-fold higher affinity for the androgen receptor than testosterone alone. So just by reducing that conversion, it actually slows down the androgen receptor, and it definitely has an immediate effect on it. It also inhibits the androgen receptor directly, so it has a 2-fold approach. Now, enzalutamide, this has a 5.8-fold higher affinity for the androgen receptor compared to bicalutamide. Bicalutamide was one of the first androgen receptor inhibitors that we ever developed. And so these are all what we call next generation androgen receptor inhibitors. So it has a 5.8-fold increased affinity for the androgen receptor. So, they're trying to say, hey, our drug is better. It has a higher affinity for it. It causes something called senescence. Senescence is something very unique. It's called cell cycle arrest. And basically what it tells a cell to do is stop reproducing. It stops it in the middle of its reproduction cycle, its copying cycle. And so that can be a very effective process. And it also, interestingly enough, it increases the benefits of radiation therapy. So it actually potentiates radiation therapy. So enzalutamide plus radiation therapy has improved, it's a synergistic drug for people getting radiation therapy. And then there's apalutamide, and it has a 7 to 10-fold greater affinity for the androgen receptor than bicalutamide. It doesn't produce senescence, but it has less penetration of the blood-brain barrier. So not only does it have a higher affinity for the androgen receptor, it's going to suppress it more, but it has less penetration of the blood-brain barrier, so it has less side effects. So a lot of doctors I know really like this drug and use it as their go-to. So here's darolutamide, and darolutamide is similar to Enza, but it doesn't penetrate the CNS, and so it doesn't have those harsh side effects. In fact, there was a recent study that compared these different receptors, and they compared them based on side effects, and it was quite startling, the differences that darolutamide had. It really made a huge difference and really reduced the side effects that most people with prostate cancer complain about. It has the highest affinity for the androgen receptor out of all of the different drugs. It also causes senescence. But most important, and the makers of darolutamide designed it this way on purpose. You may remember in the beginning when I talked about some of the mutations that can happen in the DNA of the androgen receptor. What they do is they actually prevent, these mutations occur in a region of the androgen receptor where these androgen receptor antagonists bind to it. And so when you have a mutation there, it reduces this binding site and they can't bind the androgen receptor. So if you have something called an F877L mutation, that's where the F amino acid is replaced at the 877th position by the L, or the W742L. Those are both mutations in the DNA of the androgen receptor. What they do is they prevent the other antagonists from working. And so this 877 mutation, if you have that, then Enza and apalutamide will actually bind a receptor and turn it on instead of turning it off. And so that's called an agonist. So they would stimulate it. So it's important to know if you do have this mutation, because then those two drugs are not the drugs to take. They would actually cause the cancer to grow faster. So we'll go into the next slide. And here's a description of how they all work. And as you can see here, your testosterone is produced by the adrenal glands and the testes, and it goes into the cell. This is a cell here. And then the 5-alpha reductase pathway that abiraterone inhibits, and that creates DHT. And then you can see where the other antagonists work, is they will bind onto this receptor, and they will release these two things called heat shock proteins. You don't need to know about those. These heat shock proteins basically act as scaffolds to keep the androgen receptor in the cell. And when those two remove, when the androgens bind the androgen receptor, these two heat shock proteins fall off, and they're able to translocate into the nucleus where they turn on the proliferation signaling. And this is where enzalutamide, apalutamide, and darolutamide interfere with it. They bind onto it and they prevent it from going into the nucleus. Do we have any questions on these?
Are side effects?
Yeah, so as I mentioned, the side effects are a lot to do with the penetration of these drugs into the brain and the central nervous system. So the one that doesn't have as many side effects is darolutamide. So that's kind of the latest incarnation of the drug. And I suspect we'll be seeing a lot more of it fairly soon.
Do you know what type of side effects you have?
Yeah. The side effects, from what I understand, and I am a scientist, so I'm not on the front lines dealing with this, the side effects are more based on confusion, irritability, and of course negative side effects such as the potential for strokes, increased potential for strokes, and that's obviously something that we're all concerned with. Yeah, I apologize, I don't know of all of the other. I'm sure many people who've been on these drugs would have an encyclopedic knowledge of the side effects. Okay. So I'm going to talk about the latest thing in cancer, and it's called precision oncology. And precision oncology refers to an approach that was developed about 20 years ago, 25 years ago. Chemotherapy was developed in the 70s, and this was the new approach. Chemotherapies act basically by interfering with the reproduction of a cell. So what chemotherapy drugs in general, they all have different mechanisms. When you take a chemotherapy drug, what it does is it causes any cell that happens to be rapidly reproducing, it causes it to stop reproducing. And the way chemotherapy agents do that is they interfere with the DNA and the chromosomes, so they can't separate and produce two separate cells. However, unfortunately, chemotherapy only works while the chemotherapy drugs are in your body. Once they're not in your body, then these cells can reproduce again. And also, we have many normal cells that are rapidly reproducing. And so chemotherapy affects those and it can cause problems. Precision oncology was based on sequencing the DNA of the human genome. And it took a long time and billions of dollars. But in 2006, we completed the full draft of the human genome, and since then we're able to say, okay, this mutation is causing this cancer, this mutation is causing this cancer, let's design a drug that will target cells that have that mutation. And that's what precision oncology is. Now, it's really expanded since there. And so what I like to do is I have my own take on what precision oncology is, and I like to look at it as precision oncology is the right drug for the right patient at the right time. And that is very important because each one of these aspects has a different application. And so the right drug, this looks at different mechanisms for drugs of the same class. So as we just went over those different androgen receptor antagonists, you saw that darolutamide actually works if you have certain mutations that will prevent the other drugs from working. And so that would be the right drug of the same class. So all of these drugs are androgen receptor antagonists, but knowing a little about the mechanism of each drug allows you to better decide, is this drug better for Joe, who has these mutations, or does Fred, who doesn't have those mutations, need that drug? Or could he use one of the other drugs? And so finding out who the best person is for each drug is the first tenet of precision oncology. Yes?
Doing those genetic analysis tests isn't exactly common either.
Well, the FDA has approved tumor DNA sequencing quite some time ago. It's been around for 10 years. Most hospitals in Canada have invested in tumor DNA sequencing labs. They've really come down in price now, and you can get tumor DNA sequencing for a lot cheaper. But the FDA says that everyone with cancer should get a tumor DNA sequencing panel. Once again, the future's here now, it's just not widely distributed. So we have access to many different, some of the doctors we work with swear by using tumor DNA sequencing. Others, not so much. It really depends on who they are and what their background is and what resources they have. Unfortunately, we do some small bits of tumor DNA sequencing in certain cancers in Canada, and it is catching on, but we do have a free medical system here, and the resources are extremely limited. It's not like in a private care system like the States where the insurance pays for tumor DNA sequencing for everyone, or Europe. Right now there's about 7,000 different companies internationally doing tumor DNA sequencing, and tumor DNA sequencing is the basic diagnostic tool of precision oncology. So number two would be the right person. And it looks at the context of the person's genetic and molecular features using DNA and now RNA testing. And RNA testing is a new field that's just opened up recently, and it's really changing how cancers are treated. And then, of course, the right time. And this is something that is not often looked at in standard care medicine. And we're starting to see that timing is everything when it comes to treatments. This looks at the timing of the drugs to maximize the synergy between them and in the context of that particular person's cancer. So is there any other questions on this? Yeah.
So our public health system in here, BC, do they go through this process, or do you have to go and seek it out yourself?
You pretty well have to seek it out yourself. It depends on the doctor. Some of the doctors we work with, they'll tell you right away, let's get some tumor DNA sequencing. Here's the form. It goes to a company called Foundation One, which is the FDA-approved company. Or you can do it privately. There's a ton of different companies. There's companies at UBC that do it. It's kind of a new fledgling industry that's just booming right now. And so, the prices range radically from free at some centers to up to $10,000, $15,000 for an extensive multi-gene panel. Most panels look at about 300 to 500 genes right now, and they look at a variety of different factors. And we're going to talk about how some of those factors will influence treatments above and beyond standard care, when standard cares are not working anymore. And that's really what we want to know. We want to know that there's something else for us once the standard approaches that are used stop working.
But just continuing on the last item there,
Yeah.
the right time
Right time.
in our health system is almost impossible.
Yeah. Well, we're going to talk about something that can be done.
Okay.
But yes, you hit the nail on the head. Yes. Okay. So, first of all, we're going to talk about the right time. And this is a new concept that just came out recently. Typically what happens in prostate cancer, as most of you know, you'll have a PSA rising up. The doctor will prescribe ADT, androgen deprivation therapy. PSA will go down. And then if the PSA starts coming up while you're on androgen deprivation therapy, then the doctor will use these androgen receptor antagonists that we spoke of previously. And then if the PSA rises and you become what we call castration resistant, then often the doctors will prescribe chemotherapy. So some new studies that have changed everything. This is darolutamide, and it was combined with androgen deprivation therapy and docetaxel. And this is for hormone-sensitive prostate cancers. And so this was as a first line. They used it as a first line and also for a recurrent disease. So in other words, instead of doing these sequentially, they're doing everything at once at the same time. So it's a bit of overkill. And so, as you can see here, this was the survival. And the top line is darolutamide plus ADT plus docetaxel. And what we have in cancer is we have three statistics that are important in determining what treatment is best. One of them is called the overall response rate, and that refers to how many patients on the drug out of 100 will respond. It's a percentage. Then we have the progression-free survival or disease-free survival, and basically what that is it's a median. So if you have 100 people on a drug trial, and then 50% of those patients have their cancer come back. They mark that time on the calendar, and they call that the median progression-free survival rate. And so that's only when 50%. Now, some people in the trial will be disease-free for a lot longer. So I like to show the curves. And as you can see, the darolutamide plus the ADT and the docetaxel, 62% here at 48 months. It's hard to see that. And with just the ADT and docetaxel, it was only 54%. So a significant difference there. Now, this is an interesting slide, because what it does show is it shows de novo disease. That means when you're first diagnosed, And as you can see, the darolutamide is at the top. And then in recurrent disease. And as you can see for recurrent disease, these people are pre-treated. They've had many years of treatment. They've had ADT. They've had different things. And when they did this triplet combination of all three things together, they got a significant increase in the overall survival. And so I think that's a very important statistic because it's showing even after all of the standard treatments stop working, this triplet combination together can have a huge impact and it can attack the cancer all over again. So we'll go on to the next slide. And so this was a landmark study that is really going to change things. It was called the Peace 1 study. And in the Peace 1 study, they said, we've got this group of metastatic young people with prostate cancer. So normally prostate cancer goes very slowly, but there's a small percentage of patients that have a very aggressive form of it. And by the time they get their first initial diagnosis, they have metastasis all over their body. And these people don't do very well with the standard treatment. They don't last very long. So what they did was they took this group of people and they called them, so these were metastatic castration sensitive still, and they looked at using a drug called abiraterone. That was the first one I talked about that reduces the dihydroxy pathway and also binds the receptor. And they added that to the standard ADT and chemotherapy, docetaxel. And so this is the first treatment these patients got. They got all three together at the same time. And this is just a breakdown of the different groups, because there's many different groups. Some of the patients had standard care, some had standard care plus abiraterone, some had standard care plus radiation therapy, and then some had standard care plus abiraterone and radiation. And so when they looked at these populations, they found a huge increase. And so doing the triplet therapy, it was the red line, and you can see this is the progression-free survival time. And you can see it hasn't even reached the 50% mark on this slide here, hasn't even reached the 50% mark at over 4.5 years. And for these patients, this is a significant difference because for those patients, survival is just a few years. And having this combination of drugs that we normally use, just giving them all together at the same time, instead of doing them sequentially, has made a massive difference in these patients' lives of this aggressive form. And here's another one of overall survival. And many people in this study are still alive. It's well over 6 years now. And so that's the red line there. And this is the one that I found very interesting. The patients on the left had low volume disease. So these were people with less aggressive prostate cancers. You know, the prostate cancers that grow very slowly and are usually diagnosed at a later age. The people on the right had a very aggressive form. They were young individuals, probably under 50 in many cases, but they had the very aggressive form that was moving very fast and lots of sites of metastasis. And as you can see, the triplet combination didn't have that much of an effect on a low burden disease, but it had a significant effect on the aggressive high burden disease. So once again, this also speaks to not only timing, but the right drugs for the right patients. And so if you have a slower version of prostate cancer, there may not be a need to get this triplet combination. It's specific to the aggressive forms of it with high metastasis. So this is a new study that I find very interesting. It includes 2 androgen receptor antagonists, not just one, but 2. And it was for patients with high risk, non-metastatic. So these are patients that have had some sort of molecular diagnostics, or they had a really high Gleason scale of 9 or something, and they were stratified based on their risk factor. So they're considered poor risk, you know, but they were non-metastatic at that point. So in this particular one, the progression-free survival, you can see the difference there. 108 months, significant difference in the high 80s versus just below 60% of patients have had their, so progression-free survival, once again, is how long the patients go prior or before their disease actually occurs. So very high separation of the lines here. So significant benefits, once again. This was including 2 angiogen receptors, so not 1, but 2. And this speaks to the different mechanisms that each angiogen receptor has. And so, as you know, abiraterone, it works a little different than the other angiogen receptor antagonists. It only binds the angiogen receptor weakly, but it inhibits the conversion of testosterone to DHT. And DHT has a 5 times higher affinity for the androgen receptor than testosterone. So it's hitting it from 2 different pathways. Even though they're both androgen receptor antagonists, and most people would think, well, why use 2 of them? Because they have different overlapping mechanisms. It seems to be much more effective. So once again, there is the progression-free survival, and it's at the 108th month there. So these are patients who normally wouldn't do so well because they're high risk. They have bad mutations or high Gleason scale. And so here's the overall survival, and as you can see, still high 80s at 108 months. So I think that's quite phenomenal, including 2 different androgen receptors. Now, of course, that's going to cost twice the cost, but I mean, the data is just spectacular in my opinion. Okay, so now we're going to talk about targeted therapies as part of precision oncology. So targeted therapies, right now, what's hot in prostate cancer is something called HRR, and of course you've heard of BRCA alterations. So we're going to go on to a study about that. And so this was called the PROPEL study, and they used a drug called olaparib. And olaparib is what we refer to as a PARP inhibitor. It's a targeted therapy, it's not a chemotherapy, and they combine it with abiraterone. And they used it as a first-line therapy for patients with metastatic castration-resistant prostate cancer. And so you don't see a lot of patients that show up at diagnosis who happen to be metastatic and castration resistant, but it does happen. And so obviously that's pretty well the worst case scenario because the only option for these patients is chemotherapy. There's nothing else left for them. ADT, androgen receptor antagonists are not going to be effective if you're castration resistant. And so 34% reduction in progression or death with these 2 drugs, olaparib. Olaparib is currently used as an adjuvant therapy in ovarian cancer and breast cancer. It's a readily available drug, and it's available in Canada. Just using it along with abiraterone hasn't really been done until recently. So as you can see, the median progression-free survival for the olaparib plus abiraterone is 24.3 months versus 16. Okay, and so while the study's still going on, as you can see, the overall survival at 32 months is still, you can see the orange line, which is olaparib combination, and in both groups, they haven't reached the overall survival. So these patients are still alive. More than 50% of these patients are still alive and still responding to this combination. And once again, these are metastatic castration resistant. So this is quite an advance. And we're going to talk about stratifying it based on genetic mutations. And so in this particular study, they used another drug, which is also a PARP inhibitor. It's very much the same as olaparib. It's just another company making it. It's called niraparib. And they combine it once again with abiraterone. They used it in the first line with metastatic castration resistance again. And these are patients that had homologous recombination repair defects. This is referred to as HRR. And basically what that means is they have mutations in genes that fix DNA. They fix a type of mutation. So we have a lot of genes that are turned on. They're called housekeeping genes, and they constantly repair mutations to our DNA. And so we get mutations from everything. We get mutations from pesticides. We get mutations from cosmic rays coming from space, blasting our DNA. We get mutations from breathing. Oxygen is very damaging to DNA. It produces something called free radicals that can glomp onto the DNA and mutate it. So just being alive is asking for trouble, is asking for mutations. Yes, my old biology professor used to tell me, being alive is asking for trouble. So in this particular case, these people had known mutations, and I would say that most people with prostate cancer have damage to their HRR genes. And so I'm going to show you what those are next. So you may not see it here very well, but there's a list of the genes right here. So ATM is one gene, BRCA1 and 2, BRP1, CCK12, CHEK2 is a common one, Fanconi anemia, which is FANK-A, HDAC2, PALB2 is a new one. There's actually quite a few more, but these are the ones they looked at. So if you had alterations or mutations in any of these genes, as done by tumor DNA sequencing, then you were part of this trial. And so what they found is that it continually prolongs time to PSA progression across the genetic alterations. And so as you can see, they separated these based on that combination of genes that we just listed versus just the BRCA1 and 2. And so BRCA1 and 2, you probably heard from breast cancer. They're called BRCA1 and 2. Well, now they're a thing in prostate cancer. So they're not just in breast cancer, they're in prostate cancer, they're in many cancers. We actually see BRCA mutations in probably 40, sometimes 50% of the cancers we sequence. So as you can see, quite a difference there. And once again, metastatic castration resistance. So they have no other treatments apart from chemotherapy, and chemotherapy is not that effective in castration resistance. So this gives great hope. This is adding years of survival to people who have run out of options with standard care. So as you can see, quite an increase there with the niraparib and apalutamide. And then they looked at them overall response rate. So how many patients responded out of 100 to that combination? And as you can see, the combination is on the far left. And so that's out of all of the HRR patients. And you can see it's up to 60% responded. Now, 22% had a complete response. And a complete response, this is something called the RECIST criteria. There's 4 different responses in RECIST criteria. There's a complete response, there's a partial response, there's stable disease, and then there's progressive disease. So progressive disease is the negative response. It means you're not responding, the disease is going. So it's a negative response. So a complete response is all the tumors are gone. It's like remission. Partial response means that some tumors shrink, typically over 30%. Reduction, and then other tumors just stay stable. And then stable disease is where the tumors don't grow and they don't shrink, which is still good. So in this case, 22% of the patients had a complete response, and was that 39, 38 had a partial response. So excellent compared to the placebo, which was only 28%. So knowing if you have these sort of mutated genes is pretty important. And it really speaks to the value of getting tumor DNA testing. And most people with prostate cancer, I'd say probably anywhere from 60, maybe 70% of people are going to have a mutation in one of their HRR genes at some point. Okay, let's move on. Okay, now we're talking about the right person. And there's some really exciting technologies here. So how many people here have heard of immunotherapy? Yeah, great. So immunotherapy came out probably about 8 years ago. We actually treated one of the first patients in Canada with immunotherapy. It was a young woman. She was in her early 40s. She had metastatic melanoma with tumors all over her body. And I went to her doctor. I said, there's this amazing new drug called pembrolizumab. And he said, I've never heard of it. I said, well, it's a new thing that's just been developed. It's called a PD-1 inhibitor. And so what we know about cancer is that cancer cells like to recruit the immune system. The reason is they will recruit the immune system and then they'll steal their resources. So the immune system and cancer cells use the same growth factors, they use the same hormones, they use the same foods, they both love sugars, and they use a lot of the same resources. And so because of that, cancers are smart. What they'll do is they'll trick the immune system into coming in there, and then they'll turn off the immune system and then just let the cells exist in the tumor microenvironment without attacking them. And one of the ways they do this, we believe there's about 13 or 14 different signaling pathways they do this. We now have genes for 3 of these pathways, and a new one just came out for the 4th pathway. But one of the most prominent pathways is called the programmed death 1. And what that is, it's called PD1, you might have heard it. And what happens is there's this receptor called the PD1 receptor. And think of it as one of those entrance key locks that you swipe with a card. Think of it as that. So you want to get into a building, the PD1 receptor is like the lock, you pull out your PD1 ligand, you swipe it, and it opens the door for you. So that's what happens with the immune system. A T cell, which is a killer cell of the immune system that attacks the tumors, goes in to kill the tumor, and it has this PD1 receptor that turns it off, and the tumor cells say, hey, I've got a PD1, I'm just going to turn you off. And then the T cell just sits there and doesn't do anything to the cancer cell. So what cancers do is they overexpress this PD1 protein. They create a bubble of PD1 around them. So when the immune cells come in, they see this bubble and they say, okay, this is just normal stuff, we're just going to leave it alone. And so this class of drugs called PD1 inhibitors, pembrolizumab, nivolumab, and now there's now about, I think, 6 or 7 of them. What they do is they act as like sponges, and they soak up this free-floating PD1 around the tumor. Now, I'm talking about this in a very generalistic term. It's a lot more complicated than that. But this is what they do, is they soak up that free-floating PD1 protein around the tumor, and then the immune system goes, aha, that's a tumor. So it uncloaks the tumors, and then they attack it instantly and eat it from the inside out. And so we see patients on these PD1 inhibitors that get complete long-term durable responses. They're cured, literally. So this woman had tumors all over her body. We got her 4 shots of the PD1 inhibitor. It cost her $60,000 a shot at the time. Now her medical, the medical system paid for it at the end of it because she went into complete remission and she's still cancer-free today completely. So we see this all the time. There's certain things we look for in patients now when we do DNA testing is we look for something called high tumor mutation burden, and that means if you have more than 10 mutations in a million base pairs of DNA, then you have high tumor mutation burden. And it doesn't matter what type of cancer. If you have high tumor mutation burden, then these PD1 inhibitors are going to be literally like a cure for you. Also, if you have something called microsatellite instability, or if you have mismatch repair deficiency. And these are both other mismatch repair deficiency is a DNA repair pathway. Microsatellite instability. Microsatellites are little pieces of DNA throughout our body that are unique. And they're used in forensic testing and paternity testing. Everyone has a unique fingerprint of microsatellites. Microsatellite instability is where you just have a massive amount of these. And what it does is it makes the tumor cells look very different from normal cells. So it's easier for the immune system to recognize them. So if you have any one of these things, and they're all included in most tumor DNA sequencing tests, then that means immune therapy is going to be a savior for you. And it doesn't matter what type of cancer. So the FDA has approved PD1 inhibitors for anyone that has high tumor mutation burden or microsatellite instability. Doesn't matter what the cancer is, whether it's a brain tumor, whether it's a urinary tract cancer, bladder cancer. The problem is with prostate cancers is if you don't have that, then immune therapy is not going to work. And that's because the stroma of the prostate is very dense. It's really hard for the immune cells to get in there. And so now what we're doing is we're trying to figure out, okay, how do we get these immune therapies to work in tumors types that immune therapy doesn't work so well? And we finally cracked it, and I'll show you how. So there's a drug called cabozantinib. It's actually been around for a while. It's designed for renal cell carcinoma. It's approved in Canada for kidney cancers. And they found that this actually takes the brakes off the immune system and allows immune therapy drugs to work in prostate cancer. And they're using this combination of cabozantinib and atezolizumab. It's now actually approved in about 5 different types of cancers by the FDA. And when you combine these 2 drugs in people that would never respond to immune therapy, that don't have high tumor mutation burden, that don't have microsatellite instability or mismatch repair, and that normally would not respond to these immune therapies, are responding when they add cabozantinib, and I'll explain why. So this trial here is called the COSMIC study, relatively new. Now here, as you can see, this is a chart that shows the regression in the tumors. And so below the line means how much of the tumor has shrunk. And as you can see, the investigator, that's the people who ran the trial, they found that 77% of 128 prostate cancer patients had a massive reduction in their tumor burden when given immune therapy and cabozantinib. And both of these drugs are available privately. There's a company all across Canada, private pharmacy called Innomar, and you could buy these drugs through Innomar. All you need is a doctor's prescription anywhere in Canada. They're not cheap, but they're available. And they're available for Canadians. They're available in the public system too, but the public system has only approved them for lung cancers and renal cancers, and melanomas too. That's going to change soon, but in the interim, because the FDA has approved these drugs, and because they're available, now the private pharmacies like Innomar or Bayshore Clinic can actually supply them. So we'll go on to the next slide. So I just wanted to show you about immune therapy and how it is now working on prostate cancers. So I think we could talk about that for a long time, but I really want to get into Theranostics. And I don't want to bore you with too much information. There's about 10 different immune therapy drugs available in Canada. The drug that was just used in a previous study was atezolizumab. I was diagnosed with kidney cancer about 2 years ago. I did a random scan. I thought, oh, you know, I'm in my 50s. I think I need to just get a random scan. And so I got a random scan, and the doctor said, oh, there's a little spot on your kidney. And I said, okay. And he says, yeah, we'll just let it go. We'll watch and see if it grows. I said, I don't think I want to do that. I think I want to get it biopsied. So a year later, I get a biopsy, and it comes back as renal cell carcinoma. It was a very small lump. They said, well, we don't usually do anything for tumors that small. We're just going to leave it in and see if it grows. And if it grows, then we'll take it out. So I said, I'd really like it taken out. So they took it out. And I know that there was a study that showed that if you do immune therapy for a couple sessions after you have a tumor taken out, a kidney tumor, it greatly reduces the risk of recurrence. So right now, the risk of recurrence at 5 years is about probably 12%, 12 to 15%. So it was fairly low in my case. But if I take immunotherapy, I can knock it down to about 5% or 4%. So I did that. So I just said to my doctor, listen, I know it's not covered. I'll pay for it out of pocket. He signed a prescription. I went to the Innomar clinic. I did 4 shots. The immune therapy drug cost me, I think, $3,500 a month. And hopefully that's going to reduce my risk of recurrence. So immune therapy is out there, and now we know it's effective in prostate cancer, but only in a combination. So we'll leave that for now, and we'll go on to Theranostics, which is the most amazing thing that's hit. Does anyone here know what Theranostics is? One individual came up to me and mentioned that he knew something about it. So Theranostics, do you remember PSMA? Okay, so PSMA, it's on 99% of prostate cells. A few years ago, we started noticing that after people with prostate cancer got a PSMA scan, their PSA started going down. And we thought, isn't that strange? They're just getting a scan, and their PSA is actually going down. In fact, we just had that recently. We had an individual who got a scan. His PSA was about 10, and he got a PSMA PET scan in Burnaby at the initial clinic, and then all of a sudden his PSA went down, and he hadn't even had any treatment yet. He wasn't on ADT or anything. And so what happened is they said, well, we've got this molecule that can bind lutetium and bind onto the outside of a prostate cell anywhere in the body. Why don't we use it for treatment? And so that's what they've done. And so this slide here, as you can see here, these blue dots are the PSMA molecules on the outside of the prostate cell. This is a tumor. And this is lutetium-177. And it's attached to the PSMA binding molecule, which is right there. And what happens is the lutetium and the PSMA binding molecule binds onto the PSMA receptor, and the receptor takes it into the cell, and because it's radiation, it takes it into the cell, attaches it to the DNA, and it kills the cell from the inside out. It's like a Trojan horse. What a concept. And so now we can actually get this treatment. We've actually been sending patients, they've been doing it in Germany. All of the technology for PSMA was invented by a German doctor and in Canada. A lot of it was done at UBC at Triumph, but Health Canada hasn't approved it yet. They're doing some clinical trials, but in Australia, it's part of the healthcare system, New Zealand, Germany, and so a lot of patients just go off to Germany or Australia and get it done there now. And so this is a study, the original study, it was done a few years ago. And it was this lutetium-177. So basically, it's a radioactive isotope. They inject it into you, and it seeks out all of the PSMA molecules in your body and attaches radiation to it and kills those cells. So it basically kills any prostate cell in the body, regardless of whether it's a prostate cancer cell or a normal prostate cell, because all prostate cells have PSMA, or 99%. And so this was a study done in very late stage patients. Hang on, sorry. So this is, once again, castration resistance. These patients have no other treatment. They've done chemotherapy. There's nothing left for them. And so if you look at here, the line is on the blue there. This is just the progression-free survival. So as you can see, even at 20 months, still 25% of the patients are still progression-free. You know, it's a great tool, and you can get it multiple times. We're going to go one step further than that. So I'm sure many of you have heard of the KGB and how they get rid of their agents who've run amok. You know, a lot of that is in the news and so on. They typically use a radioactive isotope called actinium-225. Actinium-225 is a very powerful radioactive isotope, but it can only travel the width of a piece of paper. That's as far as it goes. So you can carry it in your skin and you won't have any problems. You can take it through you can hold it in your hand, in your pocket like this. You can go through a radiation detector and everything's fine. It won't set it off because it can only travel this fraction of a distance. However, if it is inside your body and attached to a PSMA binding molecule that attaches it to the cell, it will kill that cell instantly. And so what the Russian spies do is they'll take this actinium-225, they'll find out, they'll find their target, and they'll drop it in their coffee. And so if you ingest it, it's going to go through your entire body and it's going to kill every organ. But what they do is they use a much lower dose and they attach it to the PSMA binding molecule. And so this is called an alpha emitter. And so the benefit of the alpha emitter is because they have this shorter range of distance, they have reduced side effects to lutetium-177. Additionally, the most important thing is so lutetium-177 is a beta emitter, and this is an alpha emitter. So alpha emitters travel much shorter distance, but they're more intense radiation. So once lutetium stops working, then you could go on to use the actinium-225, and it's now available in Germany and so on. And it's getting great results. So we're doubling up the survival, as you saw at, with lutetium, it could be, 2-3 years. We're now adding actinium to that. And so once you've done your lutetium, you can do the actinium. And this is all for metastatic castration-resistant prostate cancers, people who have no other solutions. Even more important, there's another company that's taken this PSMA binding molecule. They said, hey, let's attach a molecule of chemotherapy to it. Forget this radiation stuff. Let's use a targeted chemotherapy. And so they inject this PSMA molecule that is bound to a chemotherapy agent. They inject it into your blood, and it travels to the site of anywhere there's a PSMA molecule, and it drops this chemotherapy only in the prostate cancer cells. So you have no side effects. They can give you chemotherapy at a much higher dose, and you're not going to have this chemotherapy targeting all your other organs. It's only going to target the prostate cells. So great new technologies. So that's all I wanted to show today. There were so many different studies I wanted to show you. I wanted to show you about the PIK inhibitors, the AKT inhibitors that are doing wonderful things, the more targeted therapies. But obviously we only have a limited amount of time, and I wanted to just show you my favorite pick. And so I hope you've enjoyed that. I'm just going to follow up with a few little summaries I think are important. All these studies we shared today show that targeted therapies, immunotherapies, definitely result in statistically longer survival and better quality of life. And this is what precision oncology is all about. It's the right drug at the right time for the right person. And so, you know, genetic testing is a fundamental crux of this. And I highly recommend that everyone with cancer gets some sort of genetic testing, tumor DNA testing specifically. And then, so the 4 pillars. Precision oncology is diagnostics using genetic testing, and in this case, PSMA PET. And then personalized research, personalized treatment plans, and precision treatment monitoring. And so this is just a little slide I'd like to leave you with, and it basically covers all of the different pillars. And so the pillars are, you know, genetic testing, tumor DNA testing. RNA expression testing is the greatest new tool. It's changing everything. We're now using it for diagnostics, and we're looking at a panel of 22,000 different genes. And this helps us with rare and epigenetic cancers. So it's a wonderful tool. And then, of course, inherited mutation testing, PSMA PET, MRIs. The pre-nuvo MRI is designed for cancer. You could probably Google that we have a pre-nuvo MRI on Broadway, West Broadway. It's an MRI, no radiation, and it's designed just for cancer, a specific MRI for cancer. And then, of course, we've got personalized research. You know, having a second opinion is really important. Advocacy. We have a self-advocacy training program. We also have patient fundraising campaigns for people that can't afford treatments. You know, personalized oncogenomics, targeted therapies, you know, connecting with physicians, diet's a big factor, lifestyle's a big factor in cancer, as you all know. And then monitoring, something called liquid biopsy. We didn't touch on that, but that's definitely something for future presentations. And so, if you have any questions, I'd be happy to answer them if there's still time, Bob.
Yes, absolutely.
Yeah. We actually have a educational website on YouTube called The Cancer Guy, and we interview various you know, physicians and doctors and movers and shakers in all different cancers. We do every type of cancer there, and it's an educational, patient-based educational videos it's called The Cancer Guy on YouTube. So if you want to learn more about that, cancerguy.com. Yes.
Okay, so one more question.
Yeah.
When you're dealing with these latest treatments, I'm on a treatment plan that ultimately ends up with the operation removing my prostate.
Okay, yeah.
Would these latest treatments that you have here, sorry about that, these latest treatments that you have here, would they work for me and alleviate the requirement to have my prostate removed?
Well, you'd have to take that up with your doctor. I mean, obviously, we can't do medical advice or anything like that. These are all things that various doctors are doing now. These are all treatments that are available now. They're combinations. And so the right one for you would have to be really determined, you know, by a variety of different things by your doctors. But, you know, it's all, you know, there's many different doctors and many different approaches and many different approaches. Our job here, or our goal here, is just to educate you on what's out there. And then if you see something you like, you can pursue it and you can discuss it in more detail with your doctors. Or contact the doctors that are actually doing this. Or clinical trials. There's many ways of doing this.
Yeah, well, I'm already on a clinical trial.
Oh, okay.
But it's called GUNS.
Okay.
But it's interesting that I know that I'm going to end up having the operation on this trial. And then I'm listening for this. And that was my question.
I'm a big fan of taking cancer out when you can. Okay. You don't want to leave a ticking time bomb in you. If you can take it out. I know they don't like to always take it out when it's metastatic. And there are solutions actually in Canada, some private companies that will actually ablate the tumor in metastatic patients just so it doesn't spread more cells and so on. So there are different ways of dealing with that. But I am a fan of having the prostate removed when you can. Yeah.
Alex, when you say FDA, that's strictly United States.
The FDA is the standard for the world.
Oh.
There's EMSO, which is European regulatory agent, and now there's actually one in China. China has their own medical regulatory agency, but the ones are the FDA, and FDA is supposed to cover Canada. Most doctors in Canada, if it's an FDA-approved drug, it can take up to 10 years for it to get actual access here. We had a case a little while ago where we had a woman with breast cancer, and the woman came to us and said, I want to sequence my tumor. My doctor's tried everything and nothing's working. And so we sequenced her tumor, and we found that she had something called a PIK3CA mutation. And so I went to her doctor and I said, oh, this is what we found. There's a great drug called alpelisib. It's been out for 3 years. This drug's going to give her another 3 or 4 years of life. And he says, oh, I'll look into it. And so he looked into it and he said, oh, you know, it's available in the States, it's available in Europe, but it's not, you know, Health Canada still hasn't approved it. And so I said, okay, I'll call the drug company. So I called the drug company. I said, you know, we have this woman that wants the drug. It's not covered by Health Canada yet. And the drug rep said to me, he says, listen, I would love to give that drug to every Canadian for free. Give me a form for compassionate access, have Health Canada sign it, and we'll give this drug to every woman in Canada for free that has that, because we're still waiting. We've been waiting for 2 years. We submitted it 2 years. We're still waiting for approval from Health Canada. And so I called up the doctor. I got the form off the Health Canada website. I gave it to the doctor. He signed it. Health Canada stamped it. And within about 3 weeks, the patient was on that drug for free. So these things happen. You don't know until you ask. You know, and if it's your life, it's important to know. It's important to ask. You know, our lives, our time is valuable.
Comes back to the old saying, we were saying for ages now, you got to be your own advocate.
You do, yes, definitely. And you know, I hear from doctors all the time. I was just saying to Bob on the break, you know, doctors constantly say to me, oh, this patient told me about this new drug. I didn't know it was even available. It was approved last year, and it's going to be perfect for all these patients. And you know, I'd love to get my patients on that. And had the patient not told me about it, I never would have known it existed. So you have to be your own advocate. There's just too much information out there now, you know.
Any more questions? One more?
Yes.
You mentioned about the 4 pillars. How can one make the right choice for this personalized service?
Can you repeat the question?
Yes. So you're asking about the 4 pillars. How does someone make those choices? Anyone can get DNA testing. We have our own DNA lab, you know, so we test people. We test them for research purposes, but you know, that provides you with information on your tumor. Doctors can use that information. You can get the FDA-approved test. It's made by Foundation One, and there's many different companies. If you go to Foundation One website, what you do is you download their application form, and just take it to any doctor. You could take it to your GP, and all they have to do is sign it, and then that goes to Foundation One. They access your tumor sample, and it gets sent off, and then the doctor gets a report. And we can help you with that too. We can sign them, you know, get the forms filled out for you and tell you which test is best and so on. But any of this information can be used by any doctor, and it can be ordered by any doctor. So, and you can order it yourself if it's a research-based test. Yeah.
The testing that you're speaking of, is that invasive or is that
No.
blood test?
Well, you could do it from a blood sample. It's not as accurate from the blood, and it only looks at about 300 genes. It's best to use a tumor sample. And then we like to use a blood later on. So the tumor sample will give us all of the genes that are mutated in your DNA, all the players that have caused your cancer. And then the blood is good to see if any new ones develop over time.
So if I've sorry.
Yeah.
So if I've already had the biopsy, would the tumor sample be available
Yes,
to me?
yes, yes.
Okay.
Yeah, yeah.
Question in the
That
back?
was my question exactly.
Yes.
How long would you have access to those biopsy samples?
They keep them forever. Yeah, in fact, I think there's probably only been 1 or 2 cases where we haven't been able to access a biopsy. And we do, you know, we've done thousands of these. So, you know, it's commonplace. In you know, the States, your insurance covers it, so everyone gets it. But here, we still have to pay out of pocket. It's a tax deduction, though. So you can write it off of your taxes, at least. A medical expense.
Not much for retirement, so.
No, no, yes. Yeah.
Any more questions? Well, first of all, I'm very appreciative of Alex and Michelle coming here. They live at Sunshine Coast. When we got the address, we thought downtown Vancouver, but no, they live on the Sunshine Coast. So they've taken last night, today, to come over here and go back. So we really appreciate the time. Most of all, I appreciate the information we got